About 1 or 2% of the time, patients with large cell lymphoma will also have involvement of the central nervous system. And sometimes people call this concurrent CNS and systemic lymphoma. Sometimes they say concomitant. Sometimes they say simultaneous. Sometimes they'll say synchronous. And if you look at people when they relapse, if people relapse in the central nervous system, it often occurs in the first few months after starting treatment, so that probably it's there more often than we think it is. So that's just a reason that if people have clinical risk factors, that probably you need to look a little bit harder. This could involve the brain parenchyma or the leptomeningeal compartment, and I think I said it occurs about 1 or 2% of the time with large cell lymphoma, and certainly occurs more frequently with more aggressive histologies like Burkitt lymphoma. And then there's clinical risk factors for who are more likely to have central nervous system involvement. It turns out that there's guidelines on how to treat this. The NCCN has guidelines, ESMO has guidelines, the Spanish Cooperative Group has guidelines on how to manage, but most of the groups are just saying to treat these people with R-CHOP with mid-cycle methotrexate. So at least 3 grams on day 15 of each cycle of therapy. And generally we recommend at least 3 grams per meter squared of high-dose methotrexate, because those are levels required to create micromolar concentrations in the spinal fluid, which are what we need to eradicate the lymphoma.